Dr. Henar Albertos-Arranz is an optometrist and senior research associate at Bascom Palmar. She specializes in the study of inherited retinal diseases and the assessment of children with cerebral visual impairment. Today, she's going to be enlightening us on neuronal impairment and glial activation in diabetic patients who don't have any evidence of vascular pathology.
So good afternoon to everyone. First of all, I would like to thank to the organizer for the invitation to this interesting workshop about diabetic retinal disease. I'm Henar Albertos, but I'm here on behalf of Professor Nicolás Cuenca, who is from Spain. And we wanted to talk a little bit about this neuronal impairment and glial activation in diabetic patients without evident vascular pathology and also patients with diabetic retinopathy. So traditionally, the diagnosis of diabetic retinopathy has relied on these vascular and retinal signs that appears on the slides. However, over the last decade, we would say that there is a growing interest in knowing more about the state of the retinal cells and also the glial cells. And indeed, there are numerous studies performed in animal models that trying to analyze these signs. And also there are like another bunch of studies in patients with diabetes using imaging techniques such as OCT, OCTA, even electrophysiological testing like ERG. However, I think we are all aware of the limitation of the studies in animal models of diabetes. So this led us to question what is really happening in the human retinas from diabetic patients. So to do that, we processes postmortem human eyes from both control and diabetic patients without diabetic retinopathy or with diabetic retinopathy. We were mostly focused on the human foveas of these patients and also in the flat mount retinas in the inferior part of the macula. So in this slide, you may see we wanted to show the progression of the loss of the foveal structure during these diabetic retinopathy processes. Below, you can see from the beginning of the presence of the intraretinal cyst that continues to this huge macular edema and the complete loss of the organization of the retinal layers. But moving on to different and the specific cell types, we wanted to start with the cone photoreceptors, and as you can observe in the slides, there were we observed these distorted and misaligned axons, and also the pedicles showed like an aberrant morphology in mostly the retinas from patients with diabetic retinopathy. However, the synaptic connectivity in both the outer plexiform layer and the inner plexiform layer was already impaired in both diabetes groups, not only with diabetic retinopathy, but also without diabetic retinopathy. And going ahead, we did observe degeneration of the bipolar cells in the fovea in both diabetes groups, without diabetic retinopathy and with diabetic retinopathy. The main signs that we found in the horizontal cells was this sprouting of the terminals towards the outer nuclear layer mainly, and which can be grow up to this state that you may see here, maybe in an attempt to preserve the synaptic connectivity with the photoreceptors. And this slides, we wanted to show you how this intraretinal cyst looks like in diabetic patients without diabetic retinopathy diagnosis, and also how the retinal structure changes in the presence with diabetic retinopathy. And here in the slides, you can observe how the photoreceptors behave in the presence of this huge intraretinal cyst. We hypothesized that they were trying to preserve, again, the synapses between the bipolar and the horizontal cells. We confirmed the degeneration of the retinal ganglion cells in both groups of diabetic patients, which is this layer, as you may know, it's already been studied with the OCT, even though most of these studies are relying on of this ganglion cell complex, which includes not only the ganglion cells body, but also the inner plexiform layer and the retinal nerve fiber layer. And moving forward to the glial cells, we observe in the Mueller cells this swelling of the end feet of these cells in diabetic patients, which progressive to the complete hypertrophy in patients with diabetic retinopathy. In the case of astrocytes, we did observe these reactive astrocytes in both groups of diabetic patients. However, the statistical analysis did not reveal, in general, significant differences either in the density of the microglial cells or the area occupied by these cells, which are also interesting results, comparing with the results that the animal models were showing. We also studied the flat mount retinas of these patients, and here in the slides you can see in red how the microglia was gathered around the specific areas of the vascular plexuses in both diabetics and diabetic with retinopathy samples. We observe how this microglia was gathered around the microaneurysms in these patients, obviously this with diabetic retinopathy diagnosis. And then we also study this marker, which is the CD31 marker, which allows us to study not only the endothelial cells, but also some cells from the immune system. And this marker was accumulated within the microaneurysms. Again, this microglia was also accumulated on the neovessels of the retina in diabetic retinopathy. And with this, again, with this CD31 marker, we could analyze and study how these neovessels looks like in the diabetic retinopathy retinas. We were unsure if we can see this kind of pattern currently in the OCT, but we considered this really interesting. And finally, we could see another other signs in this retina. One of them was this accumulation of microglial cells around the laser spots. And also with the confocal microscopy, we could see these 3D microaneurysms and the presence of potential epiretinal membrane, which was causing this traction on the retina and over the vessels. So as take-home messages, and we would like to highlight a couple of things. The first one, that the impairment of the visual function in individuals with diabetes is associated with this degeneration of the neurons and the synaptic connectivity within the macula, occurring probably before the onset of the vascular degeneration. And the second place, that the results may support the development of this new classification system for the diabetic eye disease, and also highlight the need for neuroprotective and antioxidant therapies to be applied before structural alteration occurs. And finally, that this microglial activation has been observed in the retinas of diabetic patients without retinopathy, suggesting these inflammatory processes may begin earlier than previously thought, and which these signs are not limited to the diabetic retinopathy, along with the activation of astrocytes and Mueller cells. So thank you very much, and I'd be happy to answer any questions.
I have one. How do you explain, the disconnect between people who, when we look at them, have no retinopathy, but obviously you're finding changes in their neurons? What do you think is going on there? Why do you think they're not showing the other signs?
What do you mean they are not showing? Like they don't have visual changes?
They don't have the diabetic retinopathy. The ones that didn't have any, they don't have hemorrhages, they don't have anything else, but they just have the findings that you saw, that the population without diabetic retinopathy.
So, I mean, probably there are like several studies that have found decreased contrast sensitivity in these patients, that it's more functional than structural. I think OCT is a really essential tool right now, but the signs that we are seeing, like the impairment of the outer plexiform layer or even the bipolar cells, we don't really think that right now we can see that on the OCT. So I don't think it's not only the clinical signs, but also how the visual function behave in these patients.
Great talk. The microglia, it doesn't change in number, but do they more like M1 or M2 type of signatures?
So I think there is an activation of this. Do you refer to the microglia, right?
Yeah, some the old classification, although there's always new class. I mean, every month there's a new classification. The old classification is M1, M2, and M0. So M1 tend to be inflammatory.
Yeah.
M2 tend to be anti-inflammatory. Do they change?
So we didn't analyze these specifically differences. We were doing this morphological analysis based on the IVA1 positive cells, and we know how it behaves, this microglia, when it becomes reactive. This retraction of the ramification, it's something that we are seeing, and also the thickening of the cell body. And obviously that we could compare these results with the control group, which were different.
So thank you, Claire Gelfman. I'm curious about how this could be utilized in a potential clinical trial to identify the stage of one's disease that could then target, one type of therapy over another, using this mechanism as kind of a guidebook.
Yeah, thank you for your question. We think that it's really important to focus on these neuroprotective and antioxidant therapies because I think we have to know what is happening in the retina to start doing research about the treatment that can help these cells to improve their function and so. But it's true that actually nowadays it's difficult because I think we have to know more information. Most of the clinical trials are being performed in later stages, and we are thinking that if we start doing this neuroprotective or antioxidant even before we can see the structural alteration, that could help to a better, less aggressive progression of the disease.
Thank you so much.
Okay.